Well, actually, if he doesn't score a touchdown, but if he does, I'll with my team do call, like, it's not scoring. I'm like, well, keep an Allen's good. It's not scoring.
All right. How's everyone doing? Those of you who are here, sweet. I think we got about everybody, or just about, but most are online. That's fine. It's fine. So fine. Okay. So there were again. Blackboard has gave me the Stone Cold Stunner, or gave me the Super Flash Nuka, however you want to put it, but also changed the date that quiz number 4 was supposed to be due. There was somebody that emailed me last night saying that couldn't connect to the internet, but then I got online to look and it was not available anymore for whatever reason. It is supposed to be due on Wednesday, so I opened it back up. It is available at the moment until Wednesday, or quiz 4, chapter 4. I also, there was a couple people that had some trouble finishing, I think, quiz number 2 for chapter number 3. That one's going to be open. I opened it back up until this evening, so you do have a little more time. And I know there's a couple that I need to reset the quiz for. But if you were having problems finishing it, you did not finish it, please let me know, and I'll go in and reset it. If I need to extend it till tomorrow evening, that's fine. I want to make sure that at least the first few quizzes, you're able to get done. So that's that. Quizzes look good. I mean, scores look pretty good, I think. On Wednesday, pretty sure it's going to happen on Wednesday. The weather looks like it's maybe going to be a little warmer than it is today for 8, 9 in the morning. So I think we are going to be going outside. I'll send the email out with details about that and see if we can get everybody all at once. If we can't, we'll just have half show up at 8 o'clock and half show up at 8:30. So the test that we're going to do doesn't take very long. So we just got to split it up into males and females. So we're going to do it twice, I guess. So anyway, I'll let you know about that. So break things up a little bit, and then I'm sure there's going to be even more confusion about who's supposed to be in person and online. So I'll resend an email about who is supposed to be in person on Friday and online on Friday. So anyway, that's it. Any questions? Sweet. All right, short review of the last part of chapter number 4, environmental exercise, so ensuring safety, optimizing performance in any challenging environments, then exercise in hot and cold conditions, high altitude, or low oxygen environments. Then all these present low or unique challenges to the body versus what we would consider normal or thermoneutral. And where that is, 65, 70 degrees, 40, 50% humidity, sea level, that's somewhat normal for most of us. Factors affecting exercise and heat, fitness level, medication, supplements, some of that stuff will dehydrate an individual. Also change their heart rate as well. Climatization, people who are already used to it and adapted to it are going to do much better. Hydration status, exercise intensity, duration, a lot of that goes back to hydration status as well. Type of clothing that is worn, wicking away the sweat is a good thing. Environmental temperature, humidity, obviously being one of the major factors there. Factors affecting the cold, health status, acclimatization to extreme conditions. However, your body doesn't like to adapt to the cold too much. Anthropomorphic factors, body composition. This is one I don't know if I went over. I think I forgot to mention that fatter people have a better time in the cold. So there's a layer of insulation there that actually helps them. A lot of studies on that. There was one that we did in grad school. It was actually for someone's dissertation. In fact, we brought in basically heavier guys. I think it was four guys, and I can't remember what their body composition needed to be. It was over, I think 20% body fat, and then brought in a few guys that were skinnier, who were anywhere from 8 to 12% body fat. And so they dunked them in a cold water tank, and that cold water was, I think the coldest was right around 40 degrees. So for 2 hours, just sitting there. So seeing how their body reacted. In the fat guys, man, they lasted the whole time. They were fine. I mean, they were shivering. They were cold, but they were okay. The skinny guys couldn't hardly last the 2 hours. In fact, 2 of them couldn't. You had to pull them. Had to get them out, warm them up, and they were done. So the one I was getting a little worried about. It was my first experience in like a really extreme environment like that, and his lips started to look a little blue, and I'm like, maybe we should get him out of there. That might be a good thing, because I don't want to get in trouble. It's just my first year. Okay. So a little bit extra is going to help. A little bit extra fat. Exercise intensity. The more intense it is for longer, it's going to keep you warmer for longer. Type and amount of clothing, whatever that, and then environmental conditions being the big factor there. Cold, wet conditions are definitely worse than cold, dry air. And that was that. For chapter 4. Any questions, chapter 4? Chapter 5. Keeping with the exercise physiology theme, but shifting it more towards the clinical portion of it. So we're looking at conditions of the body, diseases that have developed. And this is where you can get into even more, I guess, subfields of exercise physiology. Even though exercise physiology is a subfield of exercise science, branch off even a little bit further from here, go into some really specific areas. And there's also certifications for a lot of different areas within exercise physiology, like cardiac rehabilitation, things like that. I forgot, Eli. I'm going to do it today. I'm going to do it. I'm going to make sure, I guess we won't have lecture on Wednesday, that I have an all caught up slide. Keep mentioning it. Okay. Let's go. Get on this train. So what is clinical exercise physiology? So you're using the physical activity and exercises to prevent or delay chronic disease. So always trying to prevent the bad from happening. There's also going to be some lifestyle recommendations and nutritional advice as well. Sometimes that's made by, at least the nutritional advice made by a registered dietitian. But an exercise physiologist should have at least enough of background in it that they can make some sort of recommendations. And if the unfortunate happens and there is a disease, there's therapeutic or functional benefits. And then requires understanding how the body responds not only to the acute but also the chronic physical activity. And this has to be within the healthy and diseased conditions. So knowing what the body does and how it responds, how it adapts when somebody is healthy is great, but it may change if somebody has a certain disease. So not only do you have to know the exercise and what the body does during exercise, how it responds, but you also need to know doing, guys, just going to write it up on the board. There we go. Pathophysiology of the diseases. You know what pathophysiology is?
Isn't it how a certain disease affects your body?
Yeah, basically, yeah. How it grows, how it develops, how it changes, and how it changes the body too. How it changes the reaction to the body to physical activity or stress, some type of activity. So you need to know the healthy state of the body, how it responds and adapts, but also the disease and how it develops and how that's changing the body. So you're really looking at two different fields in this case. Now, it's not necessarily need to be an expert in all of the diseases, but at least knowing the basic background of them with some specifics in there. Especially if you want to go into a certain area like cardiac rehabilitation, you should know the diseases of the heart, of the cardiovascular system, how they develop, how they're going to change the response of the heart rate, blood pressure, and even breathing rate in that, which then leads into the lungs as well. Same thing if you're treating people with diabetes, knowing how it develops, how it changes adaptations, maybe some other issues that could occur with diabetes. Any questions?
You said pathophysiology is how the body changes to activity and disease, right?
How the disease changes. Yeah. How the disease develops and how it changes. Then how basically it responds or changes the response of the body then. Any other questions? A little bit of the history, not going too into depth with the history of it, but the 1950s is when we started to develop cardiac rehabilitation programs. Most of these were supervised exercise programs. And they were just developed for people who maybe just had a heart attack under, maybe even went under surgery, under the knife, had open heart surgery possibly. Before this happened, and even a little bit past this, because it takes a little while for things to catch on, just because some people are kind of set in their ways at times. But the patients were told, say after heart surgery or after a heart attack, do not exercise. Basically, don't even get up out of bed. Stay there. You don't want to put any more stress on the heart than what is already there. But what they started to find out was getting them up and moving as soon as possible. You know, you're not going to have them running up and down the hallway the next day after heart surgery, but at least getting up out of bed and walking to and from the door within the room, having some type of physical activity, getting the heart rate up, getting the heart working. There's a lot of different I guess pathophysiology reasons for that, trying to get the heart working and get it to heal itself or heal some of the blood vessels, get the blood flowing so that we can get nutrients to whatever is damaged, remove some of the debris, some of the junk that is wherever it is, and clear it out. But also start them on a path to changing their lifestyle. Likely this individual, not always, but likely this individual had not exercised beforehand, so getting them used to getting up throughout the day and working out somehow, even if it's just a little bit of physical activity through the day. That'll help deter any further disease progression. Again, not always, but it does help quite a bit, especially in the cardiac portion of it. American Heart Association, as well as ACSM, started develop testing and training procedures for healthy. Oh, sorry, I missed something in the chat. Stagnation. Yeah, stagnation is death. It's something a lot of people don't realize is that moving the body is able to heal itself. But when you cease to move, it's more difficult for the body to heal itself. Exactly. Thank you, Eli. Yeah, and there's, I think there was a commercial too that I think it was a blood pressure medication, I think. But it said a body motion stays in motion too. So these people have not been exercising or physically active most of their lives, and you get them going, even though they had a pretty traumatic experience. If you get them going, then they might continue to exercise then throughout the rest of their life. So, and hopefully with that, reducing the risk for another heart attack or further disease progression. Again, not all heart diseases is because somebody is out of shape or terrible diet or whatever it may be. Sometimes it's genetic. I just had a guy I graduated high school with. He was 30, 35 at the time, had open heart surgery. He had 85% blockage in one of his arteries. But his dad, about 5 years ago, had a quadruple bypass surgery. So that was genetic, mostly genetic. It's kind of weird when you haven't seen him for like a year, and you show up, we're kind of at a pool, and we're getting ready to, hey, let's go swimming. He's like, oh, I can't swim. I can't swim for a couple more weeks. Why not? I had open heart surgery a couple weeks ago. What? What? Like, yeah, I'm part of the zipper club. Pulled up a shirt. Okay. Anyway, it's a story that probably don't care about. Anyway, so sometimes it is genetic. Healthy disease, testing and training procedures for them, and this is also ongoing with the development of testing and training procedures for heart patients. One of the more common tests that are made is like the stress test. Getting someone on a bike or a treadmill and basically stressing their heart, see what the reaction of the heart is. And that's been the standard test for many, many years. And I've seen at least one article recently that has kind of counteracted that a little bit. Maybe it isn't the best test to do. Maybe it isn't as important as what we once thought. Because there are other ways to test whether or not the heart is functioning properly too. Plus we also have imaging that we can do of the heart to get a more detailed view of it. A lot of different testing procedures we can do other than just getting someone on a bike and stressing their heart. So in the late 50s, also the addition of pulmonary rehabilitation programs. They started to use exercise as well. And this is, in this time frame is where, even though it wasn't coined, the phrase exercise is medicine started to be developed. So even though someone was diseased, before this, a lot of people didn't think of exercise as kind of part of the medication you give to somebody. But almost every condition and every disease, there's some aspect of it where exercise can at least alleviate some of the symptoms, some of the maybe pain, discomfort that is associated with that condition. If not potentially cure it. It's kind of a dangerous, loaded word, but could possibly at least reduce the symptoms to where they don't notice the disease. So the duties and responsibilities. Pre-exercise screening. This one has actually gone over some changes recently. I think good changes. So what you're trying to do here with the pre-screening is see how healthy they are to start off with, or unhealthy. How often do they exercise? What intensity? Do they have any pre-existing conditions that have been diagnosed? What are their dietary habits? What's their genetic profile, or what are they predisposed to? Family history stuff. Do they smoke? Do they drink? How old are they? and gender make up a pretty good portion of this, of determining how healthy they are, or at least what category they might be in. Right now, the categories that they are in are low risk and high risk. Pretty simple. Before it was low, moderate, and high, and there were some very detailed scenarios in which somebody could be considered moderate, but if one number changed, well, now they're high risk. And it was somewhat confusing. I mean, there were books dedicated to it. Now it's pretty simple. If someone's low risk, they can go and continue the exercise regimen that is put forth by the exercise physiologist or a doctor or a trainer. If someone is high risk, they need to go to their physician and go through a battery of tests to get cleared. So after the pre-screening, you go into the testing and evaluation. So not only testing them and getting the numbers from those tests, evaluating what does it even mean. How fit are they? How much can they do? How long can they go without fatiguing? And then developing the prescriptions from that. And proper training techniques, especially if it's at some point not going to be supervised. And then at the beginning, at least having some sort of supervised exercise programs. Sometimes it's always going to be supervised, depending upon the individual and the situation and the disease too. But there could be unsupervised exercise programs that someone could do. One of the stages in the cardiac rehabilitation, the later stage 3, it's on their own. So they go and do their exercises on their own without having to come into a clinic to do them or be in a hospital. Questions? Testing and evaluations. So clearing individuals for safe participation for that physical activity. That's really what you're doing. So testing them, see what they can do, see what their upper limit may be. And is there any pain involved with exercise? And if there is pain involved or discomfort, at what intensity too? Because that could also be a limitation of moving forward. So this is the basis for exercise prescriptions. So this is where you need to start. And at some point throughout the program, you're going to have to go back to this, test them again, and reevaluate. Because hopefully there is some improvement. If there's no improvement, you've still evaluated that there's no improvement and something is going wrong. Either they're not doing the right workout, they're not doing it at all if it's unsupervised, or they're not progressing like they should. There could be something else going on there, or you could bump up the intensity. Maybe they can do more than what they initially tested for. So going back, retesting them, and figuring out a new plan moving forward. So a couple different things that one would look at during these testing and evaluation is diagnostic testing. So seeing if there's any cardiovascular disease, that's the CVD, or if there's any pulmonary diseases. So anything going on with the lungs, These are two common conditions, and there's a whole bunch of specific conditions of the heart and the lungs. But a lot can be told by some type of functional testing or exercise testing. There are many diseases where exercise is not going to be able to help determine their condition, like cerebral palsy, multiple sclerosis. It might determine what they can do during exercise, but it's not going to diagnose them. Diabetes would be another one. And then the functional capacity, trying to determine their capacity to exercise. How much can they handle? Any questions on this? So diagnostic testing and functional capacity being the two biggest components of that testing and eval before the exercise programming can take place. One of the tests that you may have seen before, may have had done on you, potentially. Anyone know what this is? What's that?
Is that Wingate?
This is not Wingate now. It could be. That bike could be set up for Wingate. This one is specifically looking at the. Oh, I got someone online. The Matrix. Could be the Matrix. Yeah.
Is that an echocardiogram?
Yeah, electrocardiogram. There you go. Electrocardiogram. And go blackboard here. And depending upon what your native language is, it's either ECG or EKG. Electrocardiogram. So you're just looking at the electrical activity of the heart, in this case. And these leads or electrical nodes need to be placed in specific spots. And there are different spots that need to be placed depending upon the test that you want to do. There's also a blood pressure cuff on this individual as well. So they're taking blood pressure at the same time as doing the EKG. So EKG can determine a lot of things. How well the heart is pumping, if there is possibly some blockage, if somebody just had a heart attack, if one of the valves is not working properly. That, I guess, I'll be honest, I'm not super great at reading EKGs. Because it's something I just didn't study a whole lot. But if you want to go into cardiac rehab, you'll have classes on it, and it'll come pretty naturally. So, normal EKG, that looks terrible, but normal EKG. Oh yeah, looks super great. That's essentially what the heart is doing from an electrical standpoint. But when you actually look at it, when someone is exercising, not just a rest, but someone is exercising, this is what it looks like. Maybe not that scribbly, but pretty close to that. But there's a lot of people that can determine just from that what's happening to the heart during physical activity. And that's amazing too. Anyone? Yeah, can you guys see that okay? Online? Kind of. Pin the video, if you pin the video. I'm trying to zoom, but I cannot zoom, guys. No, that's as far as it'll zoom. I can see it. It's not overly important. Could you guys see the board when I had pathophysiology on there? No. Okay. Yes. No. Yes. Okay. I will work on this. So EKG being one of the major tests for heart patients and somebody who may potentially have heart conditions. 1 second, guys. Okay. Oh, boy. All right, so pre-testing procedures. This is related to the pre-screening of the patient, of the client. So you're pre-screening for the health risk, some sort of physical examination, if need be, by their physician. If they're apparently healthy or low risk, they generally do not need to get a physical. So you're trying to track their health history. Again, some of the stuff that I talked about was their diet, exercise habits, lifestyle. And then once all of that is cleared, everything looks good, then you have what's known as an informed consent. And this is basically stating in lay terminology what is going to take place during the programming and that they agree to those terms and they know the risks. It's also to help a little bit to save your ass in case something happens, something bad happens. Not always, but if they knew the risks, they were okay with them, and one of those risks ended up coming to fruition, and you followed all of the procedures necessary, then there shouldn't be any issues, legal issues. Shouldn't be. But that's not always the case. But it's just so that they know what's going to be taking place and they sign it, and everything should be good after that. All right. So performing the tests, some of the ones that are done, we already looked at electrocardiogram. That was the EKG or ECG. I'll write it up here for you guys maybe didn't get it online. Oh my goodness. Heart rate is an easy one to do. You can use a heart rate monitor. EKG, the EKG machine also takes heart rate. It's pretty easy to do with that. In fact, it's pretty precise. Some automatic blood pressure cuffs can take it. A lot of people's watches can do it now. Fitbits, and then just dedicated heart rate monitors can also be used. But you can also palpate. So some of you may do this on Wednesday when we do the test. How many, show of hands in person, how many of you have like a smart watch or a Fitbit or something to be able to do heart rate? Yeah, most, okay. I would imagine probably at least half of you online probably have something sort of like that. Yeah, see some head shaking. So, if you do not, we do have heart rate monitors, dedicated heart rate monitors. You could also palpate. As long as you have a stopwatch, you can palpate. So, a lot of people will do it in the neck. However, that's not necessarily a good one to do because if you press too hard, that could cause some blood pressure issues, and then I've never seen anyone pass out from it, but it could potentially happen. It's going to change the heart rate. But the one on the wrist, sometimes difficult to find, but as long as you can find it, especially after exercise, you can usually feel it somewhat anyway. But as long as you can find it and do it for 15 or 30 seconds, and multiply it by 4 or 2, respectively, should be good. We'll go over that on Wednesday, if need be. But I will have heart rate monitors available, and we can clean them easily. So, in case anyone's worried about COVID. Blood pressure, well, you can see in the picture here, that has a blood pressure cuff on, lady taking blood pressure. Rating of perceived exertion. Oh, rating of perceived exertion. This is a new one. This one is also referred to as simply RPE. Rating of perceived exertion. This is kind of a weird one because there's actually a couple different RPE scales. There's a 1 to 10. I think there was a 0 to 10 also. The most common one is 6 to 20, which sounds a little off. There's no 0 or no 1. 6 being basically resting, and 20 being you are exercising at such a high intensity you are about ready to pass out or fall over. That's pretty much what the two extremes are. The theory behind it was when it was first developed, in fact, it's really good at lining up with what the heart is actually doing, with the heart rate and the response of the heart rate for a given intensity. That's why it's used most often. But the theory when it was developed is if you're at a 0, you're not even alive. If you're 1 or 2 or 3, you're probably on your deathbed. So that was kind of the theory behind it. And it works out really well in terms of correlating very well with heart rate. So, and then oxygen consumption and functional capacity. That's the VO2 in the VO2 max that we discussed in the last chapter. So, questions? Performing the tests, you can either do submaximal or maximal. Either one. If the person is older or maybe has a condition that's already diagnosed, submaximal is probably going to be what is needed. Excuse me. If they're relatively healthy or apparently healthy, low risk, graded or maximal graded exercise is going to be good. Graded exercise just simply means there's going to be intensity increases as the test goes along. So at the beginning, it's going to be a low intensity, and then they're going to go up a stage, higher intensity, another higher intensity until they get to max. The submaximal graded is just not going to get to that maximal grade or maximal level. But from the submaximal, you should be able to extrapolate through different calculations approximately what their maximal exercise would have been. Questions? The live or the virtual? Table 5.4 in the book gives a little more detail about some of the other tests that can be run. Body composition, there are a ton of different ways to take body composition. A lot of different ways. Body mass index, let's start off with that one. Body mass index. Anyone know what body mass index is? It's also known as BMI.
It's like your fat, muscle.
It's somewhat correlated with that. It's correlated with the fat versus the muscle. Yeah.
Isn't that like how your weight and height all added in there? Just like rebuild in general, all of the ways.
Yeah, your height, your weight, and basically what your build is. So, and that should be correlated with the fat and the muscle. Should be. So BMI is just, you're looking at a ratio between your height and your weight. To give you an idea, well, the actual calculation of it, I'm sure is probably in the book. I don't know what page it's on, but and you can look it up online. In fact, there's probably an app where you can plug everything in and it just calculates it for you automatically. But it's your weight in kilograms divided by your height in meters squared is an easy way to do that. And I'm going to try to see if I can get, wow. Okay. Maybe you guys can see this online. Maybe. Height in meters squared was the BMI. Kg divided by height in meters squared. Yeah, you guys can see that. Sweet. I think if you are taking your weight in pounds, just divide it by 2.2, and that gets you your kilograms. To get it into meters, there's an actual number that you can do to just easily calculate that, but as long as you have your height in feet and inches, just make sure it's totally in inches, and take inches times 2.54, then that gets you centimeters, and then just divide it by 100. And that gets you meters. Can you guys see that online a little better? Maybe? Same? Okay. Okay. Thank you for the feedback. Well, you know what? All right, so since body mass index is a ratio between height and weight, what does it really tell us about the composition of the body? Yeah, you can look at the mass, just the overall mass.
Wait, what's the question again?
So what would body composition tell us in terms of or body mass index tell us of the composition of the body? Like the actual makeup, yeah.
Like if you're at a healthy like weight size for your height.
Yeah, if you're healthy weight versus healthy weight in relationship to your height. Yeah. Yeah, you said a bad word. Sorry. No, it doesn't really determine what where the ass is in each part of the body. In fact, that's actually a good point. It doesn't even determine where the stuff is. That's kind of the problem with BMI. It is good for a overall general population to determine how maybe big somebody is, maybe if they're at risk, because it does line up fairly well with people who are at risk for disease development, diabetes, heart disease, some pulmonary diseases. However, yeah, BMI tests mostly suck because everyone is so different. Exactly. In fact, if you're an athlete, you're likely, especially if it's a sport where you need some, well, most sports need muscle mass, except poker, right? So it's probably not the more muscle mass you have, the heavier you're going to be versus your height. Therefore, it's going to make you look like you're obese. In fact, so given the numbers with this, or showing how you get the numbers, the average and the healthy body weight should be somewhere between 20 and 25. Actually, it's, I think, 20 and 24.9, I believe, is the actual number. Obese class starts at 30 BMI. Arnold Schwarzenegger at his top bodybuilding competition was about 35 BMI. He was not obese. That's the downside of BMI, is people who are a little bit more muscular, it is not good for them because it's not going to really tell you much. Also, somebody who is maybe tall and skinny, still healthy, maybe a basketball player who's tall and skinny, it's going to look like they're underweight when they're not. They're at a healthy weight, healthy body mass overall, healthy body fat, and have a good amount of muscle. But it's just they're so tall that cancels that out. So. Yeah, many bodybuilders weigh 300 pounds more in competition shape. Yeah. Yeah, and they got these big bubble guts. There's a big controversy in bodybuilding right now about the big guts. So we'll continue this on likely Friday. Muscle gut. There you go. Yeah, it's a six pack, but it looks like they got a big old beer belly. Lumboyism. Yep, the term bubble gut. All right, if no one has any questions, any more questions? I will send an email out, let you know what's going on for Wednesday. Again, if we have to split it up, it'll be half will come the first half hour and then the second half hour. We'll get it figured out. Hopefully we can do it all at once and get it done and be done. So I'll send you the details. If I don't see you from now to then, have a good day, good Tuesday. Thank you. Bye, everybody. Bye, everybody.